Hi guys, my name is Jubilant. I'm a final year medical student and welcome to somewhat of an ASMR experience of the Weber's and Rinne's tests. So full disclaimer, it's not really a true ASMR. I'm not sure what you guys expect from ASMR, but what you'll have in this video is the ability to hear what a patient might hear if they had a hearing loss and they were to undergo these tests. So you'll need some headphones or earphones so you can truly hear the stereo sound, lateralized the tunic fork sound. So I found the Weber's and Rinne's tests quite confusing actually for quite a while, and it's only taken this long, 3 years of medical school of clinical medicine to just about grasp the concept. So personally, my goal in this video is for you to listen, and hopefully by experiencing what a patient would, you'll be able to internalize the concepts rather than just rote memorizing what each result means. I'm not going to go over how to do the test, but also the clinical correlations. I'm assuming you can do that in your own time, and there are so many better resources than what I could provide. So with those disclaimers aside, let's go over some very basic concepts. First of all, we know that the Weber's test helps us lateralize the hearing loss, and the Rinne's test tells us whether air conduction or bone conduction is heard louder, giving us an indication as to whether there is a conductive hearing loss or not. So we actually need both tests together to truly work out which side as well as what sort of hearing loss a patient has. These tests are only really helpful when there is a unilateral hearing loss, because if there is a bilateral hearing loss, the patient won't be able to tell us which side they hear the sound louder on a Weber's test. You also need other investigations in the case of a mixed hearing loss, where some patients will have both sensory neural components as well as conductive components to their hearing loss. So think of the old person who hasn't been looking after themselves very well. They've got a significant earwax build-up, so cerumen build-up, but they also, as a product of their age, have some degree of sensory neural hearing loss. Fine, so with those aside, there's one fundamental concept which underpins these investigations, and that is that the ear is more sensitive to air conduction compared to bone conduction. So sound that is transmitted through the external auditory canal, past the tympanic membrane, via the ossicles to our oval window, is essentially louder than sound that is conducted via bony conduction. And this is why the Rinne's test helps us, or this is why a Rinne's positive result, a normal result, is one where air conduction is heard louder than bone conduction. Moving on then to the pathological states, first let's look at conductive hearing loss. So in a conductive hearing loss, air conduction is no longer as effective, so bone conduction is perceived as being better than air conduction. Essentially, the truth is that air conduction is just worse than bone conduction, which remains the same. And therefore, when we use the Weber's test in a conductive hearing loss, the affected ear hears the sound louder, and there are two possible reasons to this. Firstly, there's a masking of normal environmental noise that normally reaches the cochlea when we normally hear. In a conductive loss, that environmental noise can no longer reach the cochlea, and therefore that normal environmental noise is no longer masking the sound that we hear from the vibration. The other reason is known as the occlusion effect. So we all know that our ears can let sound in, but did you know that it also lets sound out? And so in normal hearing, low frequency sounds also dissipate out of the ear, but obviously in conductive hearing loss, where there is an occlusion, this prevents the dissipation of these frequencies, therefore leading to increased stimulation of the cochlea and therefore increased sound perception. So when we perform a Weber's test on a patient with sensory neural hearing loss, the sound is heard louder in the better unaffected ear, simply because it's most likely the cochlea or the cochlear nerve that is affected in sensory neural hearing loss. So this means that the sound from the tuning fork will reach both ears equally, but then doesn't continue along its path from the cochlea or beyond on the affected side, whereas it's propagated perfectly fine on the unaffected side. I'm trying to think if there's anything more to it, but really, I think it's as simple as that for the Weber's test. However, when we perform a Rinne's test, on both ears, air conduction is heard louder than bone conduction. So let's think about this in the affected ear. So if there's a sensory neural problem, we know that it's the cochlear apparatus or the cochlear nerve and beyond which is affected. So even with air conduction, the cochlear apparatus may not transduce that sound correctly, but even with bone conduction, the cochlear apparatus is not transducing that sound. So if there is a conductive deficit, then the air conduction will not be as effective. But here, in the sensory neural hearing loss, the air conduction is completely fine. So this is why you'll get a positive Rinne's test result in both ears. One thing to be a bit wary of is a false negative result, and this occurs when there is a very severe or total sensory neural hearing loss. And in this instance, bone conduction is perceived from the contralateral working ear, and therefore when the patient hears the bone conduction, they feel that it's louder than air conduction. But that's simply because the other ear is picking up that sound from the bone conduction. Right, so let's next take a whistle-stop tour through the anatomy of the ear. For the purposes of the Weber's and Rinne's tests, there's only two real things I think are particularly relevant, and that's that the outer and middle ear transmits sound and the inner ear transduces sound. So the outer and middle ear comprise of, in my mind, everything from the pinna all the way up to the cochlea. And then the inner ear contains the cochlea, also the vestibular apparatus that we're not talking about in this video, and beyond. So the cochlear nerve, which arises from the bipolar neurons that synapse with the spiral ganglion. We can see that in this diagram on the right. That's number 1. And the cochlear nerve then traverses through the internal acoustic meatus. Just a bit of quick fire question: which other nerve apart from the vestibular cochlear nerve goes through the internal acoustic meatus? That's right, cranial nerve 7. And then the cochlear nerve meets the cochlear nuclei at the pontomedullary junction, and it has a ventral cochlear nucleus, which is number 4 in our diagram, and then the dorsal cochlear nucleus, which is number 5. So similar to the organisation at the cochlea itself, where there's a tonotopic organisation, the cochlear nucleus also is arranged tonotopically. So the higher frequency sounds actually arrive at the ventral nucleus, and the lower frequency sounds arise at the dorsal. Just a bit of trivia for you to know. So I'm not really going to expand on that for the purposes of this video. What we really just need to understand is that conductive hearing loss takes place at the outer and middle ear, in the outer and middle ear, and then problems with sensory neural hearing loss arise due to problems in the inner ear and beyond. So now let's just go through this table quickly to test ourselves. I'm just going to fire through it. Ideally, if you have a piece of paper right now, you should fill this out and then check your answers in a few seconds. So for the Weber's test, the normal ear is going to hear sounds equally on both sides, so there's going to be no lateralization. A Rinne's result in a normal ear is going to be positive, so that means air conduction is louder than bone conduction. Moving on to conductive loss, the Weber's test will localize the sound to the affected ear, so it will be heard louder in the affected ear. The Rinne's test will show bone conduction as louder than air conduction in the affected ear. And finally, with sensory neural hearing loss, the sound is lateralized to the unaffected ear, so the working or the good ear. And the Rinne's test will be positive, so air conduction will be louder than bone conduction in both the affected ear as well as the unaffected ear. Great, so if you've managed to get that, now let's go through some examples where you will be the patient with a particular loss. I'm not going to write down or show you what the deficit is first. What we'll do, we'll go through an example where we'll hear the test, we'll talk about the result, and then work out the deficit. And then we'll go through a few more examples where you work it out all in one go, and then we'll go through it just afterwards. Right, so for our first example, let's hear the Weber's test first. Right, so I think it was quite clear which direction that sound lateralized to. If you didn't hear that louder on the right hand side, make sure you've got your earphones on the right way round and you've got your laptop or computer set to stereo sound. Now let's hear the Rinne's test on the right ear first, then the left ear. And just to clarify, we'll place the tuning fork firstly on the mastoid process before drawing it back and then placing it near the external auditory canal. So after performing the Rinne's test on both ears, I hope you could appreciate that air conduction was louder than bone conduction. That is to say, the sound after we placed the tuning fork near the external auditory canal was louder than when we placed it on the mastoid process. So overall, in this scenario, with the patient having a Weber's test lateralizing to the right hand side, but having positive results of the Rinne's test on both sides, we can conclude that this patient has a sensory neural deficit on the left hand side. In this next example, I'm going to let you listen first, make up your own mind after listening to both tests, and then we'll go through the example. So starting off with the Weber's test. And now the Rinne's test. Okay, so what we'll do is we'll listen to those sounds again and I'll just narrate over them. So here, the Weber test lateralizes to the right. So I have made it slightly more subtle than the previous example, but I'm sure you can appreciate that it is towards the right hand side. Now for the Rinne's tests. First we can hear bone conduction on the right from the mastoid process, and now moving the tuning fork by the external auditory canal. And here we can clearly hear that it's louder on bone conduction. Now for the left hand side. We can hear that air conduction is louder here. So, to summarise, what we have is a Weber's test that lateralizes to the right, a positive Rinne's test on the left hand side, suggesting that there's no problem with conduction on the left, however a negative Rinne's test on the right hand side. So using the findings from the right lateralization of the Weber's as well as the negative Rinne's test on the right, we can conclude that there is a right-sided conductive hearing loss. So for our final example, just like last time, I'll let you listen to the full test, starting with the Weber's, then the Rinne's, and then make up your own mind, then we'll go through it. Fine, and now we'll have the Rinne's test, starting with the right ear, then the left. So pause the recording and make up your mind, but now let's hear it again and go through. So the Weber's test here lateralizes to the left side, so that's going to suggest a left-sided conductive defect or a right-sided sensory neural defect, provided that it's unilateral in nature. And now let's hear the Rinne's test again. So here's bone conduction. And air conduction. So you can hear air conduction louder, so that's a positive Rinne's test. Here's bone conduction on the left ear. And air conduction, which is also louder on the left hand side. So we have a bilaterally positive Rinne's test. Therefore, our findings suggest that there is a right-sided sensory neural deficit. So that concludes our ASMR experience. I know it wasn't as glamorous as perhaps you expected, so I apologise for the clickbaity title. However, hopefully by hearing what a patient would hear when you perform these investigations on them, it's helped you understand the concept. And now, just to test yourself, I have the table from previously. Pause the video and write down your answers, fill out the table. And here are the answers now for you to see. Hopefully, if you hadn't got it right the first time, you have now. If you still haven't, just take your time through the video and think through the concepts. It does take practice and repetition, so if you don't remember, don't worry. As long as you understand the concept, I think that's the most important thing that matters. So that's it for this video. I hope it was useful. Thank you very much for sticking around if you have till the end. I know it's been quite long to explain a very simple concept. Please do leave some feedback, comments below, also with anything else you would like me to try and explain. Otherwise, have a great day, good luck with your studies, and enjoy life.